This, we would move on to our next scientific session, which is living with painful diabetic neuropathy. And to chair the session, may I please invite Dr. S.K. Somani, eminent neurologist practicing in Howrah, and also founder, member of Howrah Diabetes Association, and Dr. D.S. Gwyn, practicing physician in Howrah, and also Dr. D.S. Gwyn, practicing neurologist in Howrah, and also Dr. Narayan Bhattacharya, practicing physician in Kolkata. Over to you, doctors.
Thank you all. It's a real privilege to say something or to chair a session in this national conference. So the topic is painful diabetic neuropathy. As we all know, diabetes is the second most important silent killer in the world, and diabetes population within the entire world, it is almost 40 crore, and India, it is almost 10 crore. So 1/4 of world diabetic population is in India, and out of this diabetic patient, 90% will suffer from diabetic neuropathy, and it is usually painful. So we can well imagine how much is the extent of diabetic neuropathy in our country also. So actually the pathophysiology is not very known, not very clear till date. So many postulations are there, but in treatment it is mainly anticonvulsant and anti-epileptic drugs are mainly there, that is it may be pregabalin or gabapentin, and some antidepressant like nortriptyline or amitriptyline, these drugs are there. Tapentadol is becoming popular, especially in US like that, and other some local analgesic like capsaicin cream or lidocaine patch, they are also helpful. So, and in diabetic neuropathic pain, most important factor is addiction is very important. So as diabetes itself is a lifestyle disorder, so we must motivate patients for lifestyle. Then we must try for glucose control also, because that is also very important. And third is this addiction part should be nil for these patients. And if we go for holistic type of control program, then it can help us in a great way. And that we'll know from our speaker, Dr. Debashish Chowdhury. He is in Delhi. He will be virtual. And I am handing my mic to Dr. S.K. Somani and Dr. Gwyn also. They will introduce and they will say something. Thank you.
Pain is an important component of diabetic neuropathy. About 50% of the patients with established diabetic neuropathy have pain as a significant component, and some 16% of diabetics have pain as the only component. When pain is the only component, the diagnosis may be missed because signs are few or minimal. Muscle strength is normal, deep tendon jerks are normal, electrophysiological studies are normal, because these all are subserved by large fibers, and pain is mediated by small fibers. An important feature to remember is that in the history we should ask about autonomic symptoms, because both pain and autonomic symptoms are subserved by similar small fibers. An important feature to remember in neurology is that all functions are thought to be arranged in hierarchical functions. For pain, nociceptors transmit pain impulses to spinal cord, where after some modifications the second order neurons pass to the thalamus, and finally the third order neurons go to different areas of the brain. This is the bottom of influence of pain on central nervous system. The different areas of the brain, frontal, temporal, parietal, occipital, they react to the pain and add their own valence or dimensions to pain. Therefore, living with pain living with painful diabetic neuropathy is not about pain only, it means much more. And we have an eminent neurologist, Dr. Debashish Chowdhury, to talk about the nitty-gritty of living with painful diabetic neuropathy.
Yes, it is our good privilege that Professor Chowdhury, who is the director and professor of GB Pant Hospital of New Delhi, has agreed to give a speech on this topic of living with painful diabetic neuropathy. Over to Professor Chowdhury, please.
So, good afternoon, ladies and gentlemen. I hope you can see my slides. Can you see my slides?
No, not yet.
I've shared it.
Yes, this talk is dedicated to my It's okay.
Yeah.
Is it visible now?
Yes, it's visible. Okay.
Okay, right. So, thank you, chairpersons, for the kind introduction, and I'm thankful to the Howrah Diabetic Society for inviting me to deliver this lecture and share some of the things which have already been told by the chairpersons, but I'll just make it plain and simple, and I'd like to point out certain important points for the practitioners to be mindful about the painful diabetic neuropathy. But today being the 5th September, this talk is dedicated to my teachers, and I thank my teachers for whatever they have done for me and for my being there and being able to share my thoughts with you today. So first thing is this: the diabetic neuropathies are the most prevalent complications of diabetes, affecting about half of the diabetic patients. Diabetes causes a variety of acute and chronic neuropathies affecting the nerves, plexus, or the root. Diabetes is the most common etiology for the development of a symmetrical distal polyneuropathy. And about half of all diabetic neuropathies are asymptomatic. So because the number of diabetics are so large, even half of them actually constitute a very large proportion of patients. Painful diabetic neuropathy is a common complication of diabetes affecting about a third of all people. So about 30%, 25 to 30% of all people with diabetes. It's a distressing condition affecting individuals both physically and emotionally and can cause disturbance in sleep, low mood, impotence, and social withdrawal. And in some extreme cases, it may also affect the motor functions, causing the affected individuals the inability to walk. So this is the spectrum of painful diabetic neuropathy. Before going into the actually painful diabetic neuropathies, it is better to have a just look at the classification of diabetic neuropathy. Diabetic neuropathies can be classified into a diffuse neuropathy, that is affecting all the limbs, and the nerves of the limbs, or the mononeuropathies or the mononeuritis multiplex, which is an atypical form. It may be an isolated cranial or peripheral nerve, most common being, as you know, third cranial nerve, but ulnar, median, femoral, peroneal. And of course, it can also cause mononeuritis multiplex, which is now called as multiple mononeuropathies if confluent, and then they may resemble a polyneuropathy. And finally, the radiculopathy or the polyradiculopathy, and usually the radiculoplexus neuropathy, for example, lumbosacral polyradiculopathy, proximal motor amyotrophy, thoracic radiculopathy. Now, the diffuse neuropathy, for which we are interested today, has been divided into two types. One is the distal symmetric polyneuropathy. This is the most common one, and it can be either involving the small fiber, the primarily small fiber neuropathy, primarily large fiber neuropathy, or mixed small and large fiber neuropathy, which is the most common. Or it may have an autonomic component, as was spoken by one of the chairpersons, and may have manifestation in the cardiovascular system, gastrointestinal system, urogenital, pseudomotor, hypoglycemic unawareness, and abnormal pupillary function. And this can cause a varied manifestations. And depending on the extent of autonomic neuropathy and along with the somatic neuropathy, actually the morbidity and mortality of the painful diabetic neuropathy is determined. So distal symmetric polyneuropathy. This is the commonest clinical form of diabetic neuropathy. It affects the toes and the distal foot, but slowly progresses proximally to involve the feet and legs in a stocking distribution. We know this stocking distribution. It is also characterized by a progressive loss of nerve fibers affecting both the autonomic and somatic divisions. Thereby, diabetic retinopathy and nephropathy can also occur concurrently or in succession. Frequently, the patients look for medical help only when the pain appears. The symptom that affects about 10 to 26% of this population, as I've already told, and the foot ulceration and the painful neuropathy are the main clinical consequences of DSPN, that is distal symmetric polyneuropathy, that is linked with higher morbidity and mortality. So therefore, as physicians, we must look for foot ulceration and for painful neuropathy in diabetic patients. Let us talk about evolution of this distal symmetrical polyneuropathy. As you all know, the first 10 years of diabetes, the majority of patients have no neuropathy. Then after about 10 to 20 years of diabetes, there is an increasing proportion of mild neuropathy and a modest number of clinical neuropathy. The proprioception and the vibratory perception are particularly impaired. Therefore, the role of routinely checking the vibratory sensation by 128 Hz during fall in these patients. The earliest laboratory abnormalities are the impairment of cardiovagal and distal postganglionic pseudomotor functions that occur with similar frequency. There is an early phase of neuropathy lasting about 5 years when the changes tend to become more reversible. In this phase, the changes may be responsive to course modifying therapy. So therefore, it is very important to detect this early phase by routinely screening the patients of diabetes for diabetic polyneuropathy. What are the mechanisms? Mechanisms is still not fully known, but a lot of hypotheses have been generated. The starting point is hyperglycemia. Then you have the glutamate pathway causing apoptosis, inflammation, and oxidative stress. Activation of various channels causing increased level of methyl glyoxal. Polyol pathway, sorbitol accumulation. Oxidative stress and advanced glycylation products. Injury to the lipids and myelin sheath. Inflammation. And the neurotropic factors and peroxisome proliferation activated receptors, decreased level of ciliary neurotropic factors, inhibition of PPARs, leading all and conglomerating into a clinical manifestation of diabetic neuropathy. But more recently, this research has actually shown that this actually causes the damage at the cellular level and the subcellular level. The resultant damage is caused to the DNA, to the ER, to the mitochondria, leading on to the cellular injury and irreversible damage. The yellow ones, the type 1, the blue ones are the type 2, and the hyperglycemia is the common factor, the green ones for both type 1 and type 2. As you can see, the type 1 is slightly different than the type 2, and therefore it may have an implication in terms of the treatment of hyperglycemia, which I shall discuss later. Another thing I should make you aware of this condition called a lumbosacral radiculoplexus neuropathy in diabetes, because that is also a very painful condition. It is a subacute condition characterized by pain, weakness, and atrophy of predominantly proximal thigh muscles. This is typically preceded by weight loss about 10 pounds. Patients more than 60 years typically have type 2 diabetes and have lower body mass index. They are less likely to be on insulin and fewer systemic complications like nephropathy or retinopathy. The typical presentation is that of an acute or subacute onset severe asymmetrical pain in lower extremities associated with paresthesias in the thigh region. It is typically worsens at night and aggravated on contact with clothes or bed sheets called contact allodynia. This is followed by weakness and atrophy that commonly affects the proximal muscles, including the iliopsoas and the quadriceps. As it's shown in this figure, asymmetrical loss in the proximal with severe pain. And if you do a contrast MRI, you can see the enhancement of lumbosacral roots. This is a self-limiting condition. Symptomatic treatment is required, and about 3 to 6 months, most of the patients recover. That's the good news about it. Investigations. Now, how do we investigate these patients? So first, we have this high suspicion index and the screening. Patient is a diabetes, yes, and then even if the patient is normal, then they should still be considered as a screening for diabetic neuropathy. There are certain screening tests which are being advised, and if you find that there are abnormalities, then you go in for a nerve conduction study. And even if the nerve conduction study is abnormal, it doesn't mean a thing until and unless you have excluded all other potential causes of neuropathy, because many of these patients are in elderly group, middle-aged to elderly group. So other causes of neuropathies may coexist, which needs your attention. So 3 steps: screening, nerve conduction studies, and followed by the evaluation for other causes. So for screening, clinically, you must routinely test the ankle reflex, and you use the vibration test by using 128 Hz standard tuning fork. But then there are a lot of other measures which are now available, including this neuromonofilament tests, which can be in the form of Semmes-Weinstein, NeuroPen, phone phrase hairs, and then there is a clinical test called Ipswich touch test, which can be easily learned. Then there are graduating tuning forks, and then there are tactile circumferential discriminator for 2-point discrimination and steel ball bearing stage. Recently, confocal microscopic or the cornea has also been included as a screening test for as a surrogate marker for impending diabetic neuropathy. Treatment. Treatment needs to be divided into 2 groups. One is pathogenesis oriented treatment and one is symptomatic treatment. And since we do not know the pathogenesis well enough, still it remains empirical. Of course, the foremost concern is the glycemic control. Whatever the studies have shown that the glycemic control is particularly important in primary and secondary prevention of distal diabetic polyneuropathy in patients with type 1 diabetes mellitus. However, the glycemic control seems not to influence the frequency of diabetic neuropathy in type 2 diabetic patients. So, but some recent studies have shown that the treatment used for diabetic control and not per se the HbA1c level have a role in neuropathic prevention. This explains the reason for a new study, which is called BARI 2D study. Following the treatment with insulin sensitizations, they have found that these patients have reduced chronic distal polyneuropathy incidence. So whether actually it does affect or not, obviously we would need a good glycemic control both in type 1 and type 2 diabetes patients. There was a lot of talk in the last 2 decades about the aldose reductase inhibitors. However, a meta-analysis including 32 trials demonstrated that aldose reductase inhibitors are no more effective than placebo in improving the symptoms of diabetic neuropathy and nerve conduction. By contrast, another meta-analysis showed that the aldose reductase inhibitors ameliorated autonomic cardiac neuropathy, mostly mild or asymptomatic cases. So therefore, it's a plus minus, So basically, if the patient is having a significant autonomic cardiac neuropathy, you may consider aldose reductase inhibitors in this patients. Alpha-lipoic acid is a new agent. There have been some studies which have used it in intravenous and oral forms, and they have found that these are actually helpful in reducing the symptoms, signs, and as well as the nerve conduction features in painful diabetic polyneuropathy. There have been 2 meta-analyses, one including 4 studies and later analysis of 15 trials. They have shown that probably the intravenous administration of ALA works better than the oral, but however, still for more practical reasons, oral treatment is also found to be beneficial. The other agent which has been recently tried is benfotiamine. It's a synthetic derivative of vitamin B1. And in DM, a thiamine deficiency is frequently present, particularly partially attributed to an increased renal clearance of this vitamin. Serum thiamine levels were 75% lower in subjects with diabetes mellitus than in healthy subjects. And therefore, in patients with diabetes mellitus, benfotiamine orally administered at a dose of 100 milligram 4 times a day for 3 weeks was reported to reduce the symptoms of neuropathy. The symptomatic treatment, as has been told, the level A evidence is for pregabalin from American Neurology Association and B for gabapentin, duloxetine, venlafaxine, sodium valproate, amitriptyline, tramadol, and capsaicin, right? You can use them alone or in combination. By and large, my personal preference is a combination of gabapentin and duloxetine because then I can actually use a lesser dose of individual agents and patient will not require this many high. These doses are basically for the Western population. Indians do not actually, Indian patients do not actually found these are palatable at such a high dose. But in some cases, you do have to give a high dose. And in that case, the combination might be more beneficial than a single agent. So what is the diagnostic and treatment algorithm? You have a screening test, you confirm the diagnosis, You have the symptomatic treatment in the form of duloxetine, pregabalin as a first line agent or tricyclics, and the gabapentin as a second line. And you have a pathogenetic mechanism at now at least alpha lipoic acid and benfotiamine. And then on the other hand, you know that this you need to check on this, the regular follow-up. Check for the lipids level because that has got a contributory factor. Check the blood pressure. Blood pressure should be very well controlled along with diabetes. Otherwise, the neuropathy will worsen. And finally, the glycemic control. So this is in general the kind of approach that should be applied for patients with diabetic polyneuropathy. And finally, one has to remember that the painful diabetic neuropathy does not simply produce pain, but it reduces the quality of life. There have been many studies, but one I'm quoting one recent study in which SF36 domain has been shown to have a reduced functioning, physical health limitation, pain, general health, social functioning, emotional well-being, fatigue, and emotional problems. As in, you can see that there is anxiety score and depression score are much higher in persons with painful diabetic neuropathy, and mental health and physical health both are going bad to worse in patients with painful diabetic neuropathy. So therefore, it is not only just giving prescriptions, it is a holistic approach. You have to take care of their mental state, and possibly you have to do counseling, you have to get a psychiatrist or a psychoanalyst or help for that, and also you need to talk to the patient, understand the limitations, understand where actually the patient is facing the maximum problem, and then your treatment of diabetic polyneuropathy will be successful. So, when caring for people with painful diabetic neuropathy, clinicians should consider exploring psychosocial well-being and not just prescription of few drugs, and the overall impact of the condition on quality of life, and how you can actually modify them with many other things. There are a lot of non-pharmacological interventions that can also be applied, and that you need to actually discuss with the patient, spend time with the patients, and improve their quality of life, and then only the patients are going to get benefit, and they will live at least a moderately less painful life with painful diabetic neuropathy. Thank you very much for your kind attention.
Thank you, Professor Chowdhury, for your excellent speech.